Hello all, welcome to PAN EBN 25th webinar on topic cardio-metabolic disease. Um, I'm here. I invite Dr. Prashanti Tondapu to take this session forward. Dr. Prashanti is a triple board certified endocrinologist and a lifestyle medicine physician, founder and CEO of DFW Endocrinology, with a clinical focus on diabetes and obesity remission. Forward to you, ma'am, to take over this session. Thank you so much.
Thank you, Bhavani. So I'm glad to be here today. And then I'm here in US, and I know you all are at different timings. And very happy to introduce Dr. Sundhya Raman. She's a physician with MBBS, and um, she has advanced training in pharmacology and physiology, and also PhD in genetics and epigenetics from University of Oxford. She's board certified in lifestyle medicine, both International and British Society of Lifestyle Medicine, and also she's the lifestyle medicine lead at Primary Care Cardiovascular Society, and she's a founder of My Wellness Doctor. And she has designed and led the lifestyle shifts to lower cholesterol programs in primary care. And she's the co lead faculty for lifestyle medicine and planetary health teaching at multiple universities. And she's a regular speaker on lifestyle medicine and healthy aging for healthcare professionals and public. So I would ask Dr. Raman to take over and then do her presentation.
Thank you so much, Prasanthi. I'm going to now share. Let me just make sure I have my slides ready. Yeah, so they are ready. That was a lovely introduction. Thank you so much. Are you able to see my slides?
Yes, we are able to see.
Yes.
Okay, lovely. So, yeah, I'm going to be talking today about lifestyle shifts for cardiometabolic optimization. Thank you so much, Pan India, for having me come and join you and to talk about this. There's already been a lovely introduction about me, my background, any potential conflicts of interest. So I won't go through all of that again. So I actually had a
Sorry to
very
interrupt you. Can you just put the slides on a presentation mode? We could
it's not on that.
see only
Okay.
half screen.
Sure. Okay. I'm going to just go back. I'm going to stop
I think
sharing and
you
share
could
it.
use, maybe if you could use slideshow, I think it should be good.
Yeah. What I'll do is I'll go back to doing it and put it. Where is it? I'm just going to go back to sharing my screen. And let me just see, because I've got it, seem to have it open multiple times somehow. Let me just close it and start again.
That's fine, ma'am, please.
Okay. Right. So, right. So hopefully that will be working from now. So now, is that good?
Yes, ma'am. It's clear.
Yeah.
Yeah.
Okay,
Thank you.
lovely. So, yeah, I mean, I had a really conventional kind of training, and here in the UK, we don't really practice lifestyle medicine. It's not a recognized specialty. And, I didn't really think anything about it, but my own journey started with my mum and my dad, who are pictured here. And like so many, many Indians, I mean, we are from Tamil Nadu. They both had diabetes, but it was my dad in particular who really suffered the consequences of type 2 diabetes. So he was diagnosed when he was in his 40s. By the time he was in his 50s, he'd had multiple silent heart attacks, and he ended up needing quadruple bypass surgery. And then going on into his 60s, he had more stents into those grafted vessels, and he was beginning to lose his vision. And then by the time he was in his 70s, he was completely blind from diabetes. And this meant that in practice, he never got to see the faces of three of his four grandchildren, and he completely lost his independence. And my mum, of course, she did too, because she became his carer. And so, at a time in their lives where they should be enjoying their grandchildren, their children, retired lifestyle, they were actually in and out constantly of healthcare appointments and so on. And the quality of life was really impoverished by diabetes. And my dad sadly passed away a few years ago from heart failure. And if you look at my immediate family, mum, dad, sister, everyone in orange has type 2 diabetes. I'm in green, I don't. And both sets of grandparents, most of my aunts and uncles, all with type 2 diabetes. And it really, really surprised me because if you compare our family to how most people in the West, in the UK, eat, they have always been vegetarian. They don't have ultra processed foods. They cook from scratch. They tend not to be overweight or obese. Only two of them have ever been smokers. They tend to be teetotal. They tend not to be overweight. You know, you're kind of thinking, why are they doing so much right? And yet so much is going so wrong. And it wasn't until my mum's youngest brother came to me. Now, he lives in the UK as well. And he was only in his early 50s at this time. He had been diabetic for about 12 years. He was now showing signs of kidney damage from diabetes. But the thing that worried him the most is that he had progressed from diabetic retinopathy to maculopathy. And he really didn't want to end up like my dad. And he asked me, what more can I be doing? So what I'm going to be talking about today is what I learned when I went back to the science in order to kind of figure out if there was more I could do and what I learned from that research. And hopefully this, what I'll cover today will help with your patients, maybe even your loved ones. So I'm going to start out just looking at where we are in terms of cardiovascular disease in the UK and in India, how lifestyle fits into this. How does lifestyle compare with drug treatment? And finally, what are the most impactful shifts any of us can make in our lives, our loved ones' lives, and in our patients' lives? So these two graphs here show age standardized mortality for heart disease and stroke for India, US, and the UK over the last 25 years. Now, India has seen a rise in heart disease mortality, but a fall in stroke mortality over that time, whereas the US and the UK have seen consistent falls. Now, this difference in direction for heart disease and stroke in India is largely because responses to management of blood pressure is rapid for stroke, whereas there is quite a long lag when you lower blood cholesterol for heart disease lowering. And yet, despite better risk factor management, better medication, better interventions, we can see that globally in India, in the US, and in the UK, cardiovascular disease still remains the #1 cause of both death and disability. And it is such a disheartening situation, given that what we already know from things like the InterHeart and the InterStroke study is that 90% of all cardiovascular disease is pretty much preventable, largely through making improvements to our lifestyles. Now, I'm going to focus predominantly on the UK. And the reason for this is, in some ways, it's an idealized system, both for a patient and when we're looking at population strategies for reducing cardiovascular disease. And the reasons for this is that, one, it's free at the point of access for everyone. So it doesn't matter if you're rich, whether you're poor, no matter what. Your healthcare is free at the point of access. It only depends upon what you need rather than what you can afford. It's modern, it's state of the art. We have a national health screening program for everyone from age 40 years onwards, where we do bloods, including HbA1c and cholesterol, to see if we can intervene to prevent them from developing diabetes or cardiovascular disease. So at that point, we may offer statins or other medication to mitigate that risk. And although, of course, in the UK, socioeconomic disparity definitely exists, and it is a huge driver of health inequalities. It is not as extreme as it is in places like the US and in India. So this graph here shows our cardiovascular mortality for England, Ireland, Scotland, and Wales over the last 40 years. And what you can see is that although we do have some focus on prevention, and we had been making really great progress for a number of years. Over the last 14 years, we've pretty much not just stalled in those gains. We are actually seeing an increase in premature mortality from cardiovascular disease here in the UK. And so this OECD report had a look at, well, why were we making all of that progress in driving down cardiovascular mortality for those last 40 years? And I think immediately, every time you ask a healthcare professional, they say, well, our immediate reaction is, well, of course, we're seeing a reduction. We're really good at identifying and treating blood pressure, dysglycemia, cholesterol. We have stenting. We are far more proactive about interventions. We identify things easily, more readily, earlier, and we act upon them. But what's really, really interesting is when you look at why in the UK we had been making such progress, only up to 52% of that progress here in the UK was down to our healthcare interventions. Up to 72% came down to risk factor reduction. And when I say risk factor reduction, I don't mean identifying and treating high blood pressure, high cholesterol, high blood sugars. What I mean by that was things that changed people's behavior. So here in the UK, it was things like having smoke-free legislation and a ban on tobacco advertising, or a reduction in artificial trans fats in our food, voluntary reductions by the food industry. So although here in the UK, we're really far from the ideal, just by scratching the surface, we really made significant reductions in our cardiovascular mortality. But why have we stalled? And is it just us who have stalled? If you're looking at a group of similar socioeconomic countries without that huge disparity in, having private healthcare versus, socialized healthcare. And our public health body, Public Health England, had a look at how we were doing in England compared with similar socioeconomic countries for a whole host of conditions, including heart disease. And so here, the graph on the left is for women, the graph on the right is for men. Along the bottom is the year. And along the side is the age standardized mortality. And England is the broken orange line on each graph. And you can see that we're doing better than some countries who are above us here, worse than others who are below us. But every single country that was looked at that had a similar sort of socioeconomic kind of level has pretty much stopped driving down premature mortality from heart disease over the same time period. There's one really, really striking outlier, and I'm going to come back to Finland a little bit later in this talk. So we know that risk factors have given us the biggest benefit in driving down cardiovascular mortality, things that change people's behaviors. So what are those risk factors that really impact on cardiovascular mortality? And the Global Burden of Diseases study is the most extensive, comprehensive study on the drivers of death and disability globally. It's broken down by region and by country, and this is the data for the United Kingdom. Now, along the bottom here are the percentage of DALYs, or disability adjusted life years, that we can attribute to the risk factors shown along the side. Now, one DALY is every year of healthy life expectancy that we lose to either being sick from a disease or dying prematurely from a disease. So it combines both death and disability. And both globally and in the United Kingdom, it is our poor diets that have come to the forefront, that have overtaken tobacco to become the number one driver of chronic diseases, and their contribution to cardiovascular diseases shown by that dark blue rectangle here in the UK. And it's really, really sizable. And we know that if we look here for India, again, we've got a graph at the top for ischemic heart disease, the one at the bottom for stroke. And again, dietary risks are number one for ischemic heart disease. They're number two for stroke, and high systolic blood pressure is number one, but even high systolic blood pressure has a huge element that is driven by our diets. So in some ways, high systolic blood pressure is also a composite of lifestyle exposures, including diet. That's a really significant part of that. Now, in view of how impactful improving our lifestyles are, and that out of all those lifestyle factors, our diets are the most impactful, you'd hope we'd either learn this when we're at medical school, or when we qualify, we'd have really good guidelines to help us help our patients to avoid a group of conditions that are number one cause of death and disability everywhere, and a 90% preventable. But let's look at what happens both in India and in the UK. So let's start with your guidelines, for example, the Indian Council of Medical Research. Now, I know that unlike here in the UK, India doesn't have one unified lifestyle medicine guidelines for cardiovascular disease. It's fragmented across various non-communicable disease policy documents, as well as different consensus statements. So we're going to have a look at various statements from different bodies. So if we look at the ICMR, they give some really confusing guidelines, in my opinion, about type 2 diabetes. So percentage of energy from carbohydrates, protein should be 12 to 15% of total energy. Fats should be 20 to 30% of total energy, of which saturated fats should be less than 10%. And 7% in those with raised blood lipid levels. And of course, what that's really asking us to do, or our patients to do, is to weigh each piece of food, work out where the saturated fat is, what percentage of it may be protein, what percentage of it is carbohydrate, etc., and then work out our caloric intake for the day, and then see if this percentage is, it's a lot of complicated maths. It's really not very actionable, and it's exactly the same in the UK. We have the National Institute of Health and Care Excellence, or NICE as we call it, and they provide best practice guidelines for all conditions, and they do give some lifestyle advice. So if we look at, say, type 2 diabetes, they say encourage people with type 2 diabetes to follow the same healthy eating advice as the general population. Now, it's such beige advice. It's so sort of, eat healthily, that actually nobody's going to say this to anybody, and no patient's going to, everybody knows they could eat better. So it's not really helping our patients to do anything more. And cardiovascular disease, again, just as confusing, just as unactionable. 30% or less of total energy, 7% or less of total energy from saturated fats. Where are these saturated fats? So it's quite mired in maybe research-based talk, but really not actionable, clinically usable guidelines. And if we look at your Cardiovascular Society of India, I'd say that it's even worse. So they start off quite well. They say food pattern choices and preparation influence health, rather than rigid counting of calories and proportion of macronutrients. And I agree with this. But then there's some really quite confusing things amongst these guidelines. They say that higher intake of saturated fats, the cholesterol slightly increases with higher intake of saturated fats, but restriction has no discernible effects on atherosclerotic CVD incidence or mortality in randomized trials. And this is a big red flag for me, because I'm going to go and talk in a little bit about the evidence behind this. And I say this is in direct contradiction to the evidence base and other consensus guidelines. If we look, for example, at this American Heart Association Presidential Advisory, they actually say that randomized controlled trials that lowered intake of dietary saturated fat and replaced it with polyunsaturated vegetable oils reduced cardiovascular disease by about 30%, similar to the reduction achieved by statin treatment. And carrying on with the Cardiovascular Society of India's guidelines, they say that dietary cholesterol has a neutral association. And actually, this isn't true. If we look at the three types of fat that drive LDL or ApoB in the blood, they are by far the most toxic are trans fats, by far the most prevalent, the highest in volume are saturated fats, and cholesterol does have the least impact. But about 15 to 20% of the population are what we call hyper responders to dietary cholesterol. So if we actually look at the foods in this Venn diagram, in which you find trans fat, saturated fat, and cholesterol, it's the same foods again and again and again. Red meat, poultry, dairy, ultra-processed foods. Eggs have saturated fat and cholesterol, and then we have palm oil and coconut oil. These are high in saturated fats. So it is this combination of foods that you really need to massively reduce or completely eliminate from your diet if you want to protect yourself from cardiovascular disease. And we pretty much look at LDL cholesterol or ApoB as being much like smoking. You know, it is your levels against your duration of exposure that really drives your risk. So maybe if you are early in life having very small amounts of these foods, you might never develop cardiovascular disease. But if you're like most of the population, you're consuming a good amount of these day to day, and you're cumulatively increasing that exposure. And so by the time we're, identifying people with high cardiovascular risk factors, they really need to reduce or eliminate these foods, because otherwise they're just topping up their LDL cholesterol. If they just reduce it a little bit, just more slowly. These need to be eliminated from the diet at that point. Similarly, they then go on to be very wishy-washy. They say healthy diets are plant-based, but actually have an omnivorous diet with eggs, dairy, and occasional intake of unprocessed meats. That's fine. And I think this is really, really confusing guidelines and very contradictory. But what you'll find is actually there's enormous consensus on what constitutes a healthy diet. And these international consensus guidelines would rather than looking at, well, you need 15% of calories from protein and 50% from carbohydrates and 10% of calories from fats, these consensus guidelines I'm going to show you demonstrate, one, that there's enormous consensus on what a healthy diet looks like, how you prevent cardiovascular disease, and two, that we can very, very simply, in one sentence, tell any person what a cardioprotective, cardiovascular, cardiometabolic, cardiorenal protective plate looks like. And they can just eyeball that plate and say, oh, yes, I don't need to do any calculation. This is what a diet that is going to protect my heart, protect my brain, protect my liver, my kidneys, protect me from cancer looks like. So let's start with cardiovascular disease. The European Society of Cardiology guidelines are my favorite. They say adopt a more plant and less animal-based food pattern. Now, if anyone looks at their plate and they go, is this mainly plants? At most, am I accessorizing with animal-based foods? Or are most of my plates just filled with plants? And maybe once a week, I have some animal-based food in there. That's maybe acceptable. What about the American Society for Preventative Cardiology? They say the American College of Cardiology and the American Heart Association recommendations can be met with a Mediterranean plant-based diet, dietary approach to stop hypertension, healthy vegetarian, and exclusively plant-based diet. What about type 2 diabetes? Well, the Diabetes Task Force of the European Society of Cardiology, because of course, we can't separate these two conditions. We can't sort of silo how we manage them, because the inevitable consequence, the biggest risk for every single patient with diabetes is micro and macrovascular disease. So their Diabetes Task Force recommends a Mediterranean or plant-based diet, and again, to shift from a more animal-based to plant-based food pattern. The European Association for the Study of Diabetes again recommends a Mediterranean, Nordic, or vegetarian dietary pattern. And we see the same guidelines again if we look at kidney guidelines from KDIGO and KDOQI. We see the same for liver guidelines from European societies, and we see it the same thing in cancer guidelines. So in fact, what we're really doing is providing the same guidelines in order to help people preserve their health, rather than become the typical person that ends up with not just one chronic disease, but multi-morbidity over the last few years of their lives. So let's see this in action. The Lifestyle Heart trial was a 5-year randomized controlled trial performed by Dean Ornish in the States, whom I'm sure many of you have heard of. And his, as I mentioned, was a multimodal lifestyle intervention that included a whole food plant-based diet that was low in fat. They encouraged aerobic exercise, smoking cessation if needed, stress management, and group support. It included 48 patients with moderate to severe heart disease. Now, all of the patients at baseline had an angiogram, which was blinded in the sense that the person doing it didn't know which group they had been randomized to. And then after 5 years, they repeated the angiogram and they looked at the mean diameter in stenosis and the change in that mean diameter. In the control group, there was a worsening of the stenosis on average by about 27.7%. Now, in the lifestyle intervention group, there was actually a regression of their stenosis by 7.9%. Now, what is even more striking about this lifestyle intervention group is that nobody in the lifestyle intervention group was on a statin. So when you took the subgroup within the control arm who weren't on a statin, they had a worsening of their stenosis by 46.7%. So this is the true comparator between our control arm, standard medical management arm, and our lifestyle intervention arm. I say standard medical management, it's not that standard to not be on a statin, but this is the true comparator. And if we look at the major adverse cardiac events, they were more than double in the standard medical management arm compared with the lifestyle intervention arm. Now, what if we only looked at dietary intervention alone? The PREDIMED trial was a primary prevention randomized controlled trial, including over 7,000 participants who were all deemed at high risk of cardiovascular disease. So they had a high blood pressure, or they were smokers, raised BMI, strong family history, things like this. And they were put into one of three arms. The control arm, again, underwent standard medical management, and each of the intervention arms was asked to follow a Mediterranean-style diet. The first with the addition of 4 tablespoons of extra virgin olive oil each day, and the second with the addition of 30 grams of nuts a day. That's roughly a handful of nuts. And they had a composite outcome of MI, stroke, and cardiovascular death. And what they found was that each of the intervention arms had a 30% reduced risk of these adverse outcomes compared with standard medical management alone. The Leon Diet Heart Study was a secondary prevention randomized controlled trial. It included over 600 participants who had each suffered an MI but was now clinically stable. And they were put into one of two arms. The first was the control arm, was given standard medical management, and the intervention arm again was asked to also follow a Mediterranean-style diet with the addition of alpha-linoleic acid, which is an omega-3 fatty acid that's particularly high in foods such as walnuts, flaxseed, and soya. Now, they had 3 composite outcomes. The first was cardiac death and non-fatal MI. The second was everything in group 1 plus unstable angina, stroke, heart failure, and either peripheral or pulmonary emboli. And the third composite outcome was everything above, plus hospitalization for any cause. And again, the intervention arm had significant protection against these adverse outcomes compared with standard medical management alone. And if you compare that with this meta-analysis for statins, for primary and secondary prevention, I hope you could see that lifestyle intervention really isn't the poor cousin of standard medical management. It really should be front and center of our management of all of our patients if we want them to have the best possible outcomes. And it's never really going to be an either or scenario. We would be doing both for our patients, but I think that most healthcare professionals think it's something that's just nice to have, and they don't necessarily know what to say. And the consensus guidelines and the evidence shows that it's really impactful and not that hard to do. So what about Finland? Why are they so different to all the other similar socioeconomic countries? Well, I'm going to tell you a story about Finland and maybe why they're bucking the trend. So this beautiful lake and forest-filled province is North Karelia, just on the eastern border of Finland, on the border with Russia. Oops, sorry about that. In the 1970s, they had the unfortunate distinction of having the highest cardiovascular mortality in the entire world. Now, why was this? Well, after the Second World War, Finland suddenly had a lot more money, including North Karelia. And so they decided to develop a dairy industry. And so foods that had previously been really rare and luxurious became a lot more prevalent in this region, and it was killing them, essentially. They started eating a lot more animal source foods and their diets changed hugely. And they had really, really high cholesterol levels. Now, statins didn't exist at this time. So they had no choice but to deal with the underlying drivers of cardiovascular disease. So they focused on changing people's diets and beginning smoking cessation groups. So they had the most enormous public health campaign. They went into schools, they went into the food industry, they went into government buildings. They taught people how to cook and essentially follow the European Society of Cardiology's guidelines in their flavor, which was to adopt a more plant and less animal-based food pattern. So in 1972, 51% of men in the region were smokers. So I don't know if I mentioned they began smoking cessation groups. By 2012, 36% of men were smokers in the region. In 1972, 90% of households used butter. By 2012, it was less than 10%. And this is what they saw. There was an 84% reduction in cardiovascular mortality in the region. The initiative was so successful, they rolled it out across the whole country within 2 years, who overall saw an 82% reduction in cardiovascular mortality. And, I think you can see there's never been anything like this in any other country focusing on the upstream drivers. And they seem to be having a much greater legacy benefit from what they did. So what are the biggest impact lifestyle shifts? Absolutely prioritize the plants on your plate. To get the biggest benefit, they do need to be minimally processed and whole grains repeatedly. So brown rice, millets, oats, barley, unpolished barley, things like this. They should be a big part of the plate, repeatedly. White rice, which is, my family have always been eating white rice. We need to swap these things out. And we should be prioritizing them. They repeatedly come up as the number one food we should all be eating more of in order to reduce our cardiovascular and chronic disease risk. Now, even low levels of physical activity help. I think a lot of people feel that they need to be quite fit before they gain those benefits. And sometimes this can stop people beginning to increase their level of physical activity. Now, here in the UK, our guideline amounts are that you should be aiming to achieve 30 minutes of moderate intensity exercise 5 days a week. So to achieve 150 minutes of moderate intensity exercise over a week. Now, this is our chief medical officer's physical activity guidelines, and it's a dose response relationship between how much physical activity we get over a week and when we start getting the health benefits. And these guidelines of 150 minutes a week is actually when the curve begins to flatten. The steepest part of the curve is when somebody goes from doing nothing to doing something. And this can be really, really motivating for patients when we say to them that the instant they begin to increase their level of physical activity, they are reaping the benefits of that. It can be really, really encouraging. And if they want to gauge whether they're achieving moderate intensity, because they don't have to go to the gym, it doesn't have to be structured. If they're, say, doing some housework or gardening or, just being active, they should be able to hold a conversation, but not sing a song. And that's how they can gauge whether they're achieving moderate intensity. Now, I see a lot of people struggling with their sleep. And of course, there can be medical reasons like obstructive sleep apnea driving this, and that's important to identify, but a huge amount of it is behavioral. So I'm going to do a really quick primer on sleep for just some help with behavioral change. Sleep is governed by two chemicals, adenosine and melatonin. Adenosine is our sleep drive. Adenosine levels in our blood accumulate over the course of the day, and then they reach a threshold, and then we find sleep really difficult to resist. Adenosine is antagonized by caffeine and alcohol. So if people are struggling with their sleep, this needs to be titrated back or minimized or avoided in order to help people feel sleepy in time at night. Melatonin, nearly everybody knows, is inhibited by blue lights from our screens, but actually we need to think about our evening lighting in general. It should be like a campfire. So it should be in the warm spectrum, not blue and white lights, but more sort of yellowy orange light. And it needs to be low down. And the reason for this is, so rather than overhead ceiling lights, and the reason is that in the inferior aspect of our retina, we have intrinsically photosensitive retinal ganglion cells. So these are not just particularly sensitive to light in the blue spectrum, but also light that comes from above. So that's why it needs to be low down, like table lamps, and in the warm spectrum to trigger melatonin release at night. And also melatonin is triggered by a contrast between our day and night light exposure. And because our pupils are so responsive, we don't notice this, but even very, very bright indoor light doesn't have the same intensity as daylight outdoors on a cloudy day. So even in the winter, even on a cloudy, dreary day, encourage people to get outside, ideally first thing in the morning without sunglasses to trigger melatonin at night. And much like children, we can train our brain and body to anticipate sleep. So for example, encourage people to have a relaxing wind down in the evening. So that might be having a shower, brushing your teeth, reading, and then set an alarm to allow yourself that wind down towards bedtime. And I find certainly with my family, with my kids, if I say, okay, it's time, we all need to start heading to bed, versus whether if an alarm goes off in the house and says, right, for all of us, we need to start winding down, heading to bed, begin our relaxation routine, they don't argue with that alarm going off, whereas they would argue with me. So finally, I should actually let you know what happened to my uncle. So along the bottom is the year and the month. These green bars represent his urinary ACR. So the fact that they're in this sort of yellow zone means that his kidneys were leaky and filtering out proteins they shouldn't have been filtering. So his urinary ACR was raised. This blue line represents his HbA1c, which was just going up and up and up despite everything he was trying to do. Once we began our lifestyle intervention, not only did his HbA1c plummet whilst coming off his diabetes medication, his kidneys healed themselves. They stopped filtering those large proteins. His urinary ACR normalized, but most important of all, back in September 2018, he had diabetic maculopathy. By February 2020, he had no signs of diabetic eye disease, and that remains the case to this day. So finally, just some resources. I'm a member of Plant-Based Health Professionals. That's in fact how you guys got in touch with me, is through Plant-Based Health Professionals. I mean, we do very much the same kind of work as you guys. We have a lot of podcasts. We have a podcast. I've done a podcast. There are two GPs who run our podcast, covering all sorts of aspects of nutrition and lifestyle medicine. And I did one episode with them that's quite in depth, called Beans versus Genes. So please do have a look at that. I cover a lot more about cardiovascular disease in there. We have various free fact sheets. We have webinars, online webinars. We have conferences that are mixed, both some of them are in person, some of them are online. And so, please do visit the site and have a look at our various fact sheets and so on. I co-lead on the university education at Plant-Based Health Professionals, but we're certainly very, very similar to you in terms of our aims and our objectives. So thank you so much for having me. I'd be delighted to take any questions.
Thank you so much, Dr. Raman.
Oh, an absolute pleasure.
Yeah, so it was great. And then it's good to know about the European guidelines and also about the changes that you have mentioned in North Carolina. So, do you have any suggestions? Like, I mean, if we have to tell people with cardiovascular disease, like a simple way to say, okay, we went through so many guidelines, confusing guidelines. So, is there like one or two sentences in the visits that you would advocate for everybody, including the primary cares? Hey, this is how you should be eating.
Yes. So this is why I love those consensus guidelines, because our guidelines are much like your national guidelines, and our British Cardiovascular Society doesn't give any decent dietary guidelines either, which is why you have to look a little bit further afield. So here in the UK, we're much like India, where we're talking about macronutrients and we're making it very, very confusing. And my favorite, and I think that this is so strongly borne out by the evidence, is we do need to move from adopt a more plant and less animal-based food pattern, and the higher your risk of cardiovascular disease. So, for example, when we're looking at secondary prevention, if you already have a raised cholesterol, you need to be adhering to that concept very rigorously. And the thing that I often say to patients, and when I do say groups, for example, and we can be really wishy-washy and say, well, try and have a little bit more, you can swap out a little bit here and there, but you need to be so much more rigorous on this once you have those risk factors established. The reason being, I say to them, if you imagine a cup and it is full of cholesterol, if you carry on eating lean meats and low fat dairy, all you're doing is you're topping that up just more slowly. If you want to drain that, you have to absolutely populate your plate with foods that are going to lower your cholesterol, and those are plant foods. You need to absolutely crowd out all of those foods that are driving your disease. And we know it's not just the saturated fats, the trans fats, the cholesterol in that food, it's the heme iron in that food. We know that it changes our microbiome. So in people who have omnivorous diets, they populate their bowel with particular bacteria that every time they eat meat and so on, they produce something called trimethylamine that gets converted in our liver to trimethylamine oxide. And that's very atherogenic. We know that when you cook animal protein, particularly if you dry cook it, grill or barbecue it, it produces advanced glycation end products. These are found in so many, driver of so many conditions: dementia, diabetes, cancer, heart disease. And so, it is not simply the fats, the protein, it's the heme iron, it's the whole composite of these foods. And so, we are often reductionist in order to understand things better. But now at this stage, we understand it at a micro level. We need to step back and go, what is consistent here? These same foods are the biggest driver of diseases and the biggest driver of all of these diseases. So number one is diet. And this is where I think the biggest difference exists between what we actually do and what we should be doing. And we have such a strong evidence base that this is completely avoidable. So number one is take the animal source foods off your plate. And in India, I think, so my family have always been vegetarian, but our dairy intake was absolutely massive. And, this was where, certainly for my uncle, the biggest change came when we took dairy off his plate. Until that point, I had been sort of, saying, well, why don't we add a bit more protein to your carbohydrate, do this, that. We were doing all these tiny shifts. We took dairy off his plate, boom, everything plummeted. And I think this is something you'll know a lot more about, but I do think the pathology of type 2 diabetes is so different in South Asians compared with Caucasians. So we have a predominance of research done in white populations, but the pathophysiology is different in Indians, and I think that we in South Asians, and so we really need to be a lot more proactive about this earlier, much earlier, even in utero, preconception. We need to be thinking about our metabolic risk all that way, and it comes repeatedly down to the same advice: take the animal source foods off your plate.
Yeah. So thank you for saying that. And there are a couple of questions here. It says, what's your opinion on yogurt, especially in patients with it's IBS with
Yogurt.
raised LDL. Yeah.
Yeah. So if we look at dairy as a whole group, the worst outcomes are with milk and with butter or ghee or whatever. And these you really, really should avoid. We often get a more neutral impact with yogurt and cheese. However, I have found that once you have reached that tipping point where you have a raised cholesterol, you're already, for example, plant-based. And I think culturally, this was really difficult for my family. If I really think about the dairy that my family ate, we would have yogurt with every single meal. And we'd think, oh,
Yes, right.
there's so many probiotics. This is such a healthy food. This was one of the biggest things. But, subsequent to that, I've taken yogurt off the plate for my family. And again, I'm seeing a reversal of kidney damage and eye damage. And I really think that once you reach that precipice, and I think that in our population, I think we are particularly at risk. So we have soya yogurt, for example, in our family. And there's probiotics added to the soya here. It's not genetically modified. You're not allowed to have genetically modified soya in the food system for humans here, although it is fed to animals here in the UK. In the US, I know it's different. So, that is a really healthy substitution in our family. So, I would argue that whilst if you look at population-based studies, it comes out cheese and yogurt come out relatively neutral. I think when you have cardiovascular risk, you should avoid them and substitute them with foods like soya that lower cholesterol, are associated with improved metabolic outcomes, also reduce your risk of breast cancer, womb cancer, and prostate cancer. And so I would argue, every opportunity there is to substitute in a better food, you should do it. So yeah, I mean the research is variable. It stratifies dairy foods in that way, but it is not something that I've learned from experience that you need
Yeah.
to take it off the plate from people with a higher risk. It's different when you're looking at kids. If you're predominantly adding in those plants, taking away the refined grains, I don't think it's so harmful, but I think there are better choices. So my children have soya yogurt because certainly when we look at girls, the best breast cancer protection comes when you introduce soy from a young age, and it has no negative impacts on male reproduction, none. And we've
So
seen that
the
really.
question, yeah,
Yeah, sorry, I've
sorry to
gone off
interrupt
track a
you.
bit.
Yeah, there are a
Yeah.
few more questions. So I will just first read the questions so we don't, go behind. So on with you mentioned soy, but then there is also a question about like ages. Are they not high in tofu? Is one question, but also
Sorry,
somebody
which ones are they not high in tofu?
ages advanced glycation and products. I believe that's what they are
No, they're
saying.
not.
Is it high in
No.
tofu? Is one question. Okay, thank
Yeah.
you. And then the other one is from a cardiovascular standpoint. They are saying the new US food pyramid has been flipped. Yeah, I am sad about that too.
It's
With carbs
horrendous,
reduced
isn't
and
it?
it is. Yes. And I mean, yes, I put it in the groups too. Like, yes, I know like we are all sad about it, especially the lifestyle physicians.
It's
But the
shocking.
question
I
here
think
is
there's a lot of
specifically
worrying things.
how do different types of fats versus carbohydrates influence the cardiometabolic risk and long-term heart health?
Hmm.
Yeah, and then there is a question about like moderate intensity exercise. But they are asking that 150 minutes, does this include only the structured exercise program like cardio hit, or does it also include everyday tasks like gardening and household work? And I
It's
think you have
everyday.
mentioned it. Yeah.
Yeah. Yeah. So again, when we look at cardiovascular disease, replacing saturated fat, the biggest benefit is from replacing it with polyunsaturated fat, followed so most oils, apart from rapeseed, also I think it's called canola oil, is that right in the US? And extra virgin olive oil. Those are both monounsaturated fats. Replacing it with refined grains, you don't see a benefit. But of course, complex carbohydrates, whole grains, you do see a benefit. So a lot of the studies, they may not replace those saturated fats with healthy alternatives. But if you replace it with polyunsaturated fats, monounsaturated fats, or complex carbohydrates, you get cardiovascular benefit. Um, so I think that was one of the questions. As you mentioned, the physical activity guidelines, it's not structured, it's all. We used to have a minimum of 10 minutes, but what we've learned continuous exercise, but we've changed those guidelines to any increase because what we've been learning from people wearing wearable devices is that you start to accrue those benefits even if they're in very short bursts. And it applies to non-structured exercise. Anything where somebody gets slightly breathless, slightly sweaty, it doesn't have to be high intensity.
Okay. And there is a question about like the NHS. So they said, thank you for the detailed session. I understand lifestyle medicine isn't covered by NHS yet and needs to be paid out of pocket, but it's the same in India. So can I ask for your advice on how to run a successful lifestyle medicine practice and draw in enough patients? I think that would be helpful for everybody based on your
Okay,
experience.
so actually, it'll probably be much better in India, America, anywhere where there's a private healthcare system, because people naturally are going out and looking at the market and they're seeing what's out there. Here, it is not so easy. In fact, a lot of the work I do is with the NHS. So, although and it's a little bit, I've been very, very fortunate in that I have ended up being in a position to contribute to consensus guidelines, to teach healthcare professionals and so on. So I'm working with a lot of NHS organizations to, there's a strong understanding that we have to shift towards prevention because it is economically for the NHS unsustainable. So actually, it's quite hard to be a lifestyle medicine doctor practicing privately here in the UK. I think in India, it will be far better, far easier to practice as a lifestyle medicine doctor. So I'm not sure that I have some really good advice on how to do it, because I have simply enjoyed, done whatever I enjoy. And I think whenever you do anything with integrity and with love, good things will come from it. So I've been very, very fortunate because I haven't really just done things for financial reasons, but because it sits very comfortably with my ethics and my beliefs as well. And I think people can tell that. So it's been a really positive process for me. And I certainly think that when I compare my lifestyle medicine experience with my conventional kind of hospital-based experience, the ability to reverse disease was so unexpected for me. I think that, I started out very slowly and kind of, oh, this is all theory. I'm not sure I really believe it. And then I was practicing on my friends and family, and I was really astonished by what could be achieved over very short periods of time. So it is one of the most rewarding things to do in my experience, in my belief. But I feel like you in India, and I feel like people in the US can easily bring lifestyle medicine within their conventional medical practice. And I think that's a win for everybody. So, we are actually starting to bring it in here in the UK into more NHS kind of practice. But we, like all sort of healthcare systems, we need a lot more funding to begin that process. But it will be happening.
Yeah, funding is the biggest issue, I think. But
It always
I
is.
mean, like, but I thoroughly enjoyed your presentation and everything. I think
Thank
there
you
is
so much.
yeah, I guess that's about the questions, unless someone wants to talk more. But like I said, I have thoroughly enjoyed the guidelines. I mean, your insights and and the work and everything. And it's good to know because this thing about the dairy comes up a lot. Like, okay, should
Yeah.
we be doing dairy? And what about yogurt? What about other things? So this is a common question. And one thing I want to end with, I have a question. So you mentioned about Southeast Asians versus other people, right?
Yes.
So with regards to medications or anything, I mean, again, there is whole concept of, okay, what is the actual BMI that you would be looking for? And now there are no specific guidelines saying, okay, this is obesity in Asians because the BMI is much, much lower in Asians. So
Yeah.
with regards to the cardiovascular disease and the way like most of the Asians eat, do you have any recommendations or any suggestions on the testing for cardiovascular disease for the Southeast Asians or in general South Asians? And
Yeah.
then what can they do for the prevention?
So exactly as you said, I mean, it's so with the BMI here in the UK, for example, amongst Caucasians, we start to define risk with a BMI above 25, whereas it's above 23.5 for South Asians. And even when we look at different ethnic groups within the UK, Bangladeshis, their risk is more like at 22, a BMI of 22. Then we have Pakistanis, then we have Indians, then we have Black populations. So we start to see different subpopulations within the UK. Now, of course, we are looking at sort of first and second generations here. So it's slightly different, but what we're, you know, the BMI is important, but I think a newer measure that people are moving towards is your waist circumference should be less than half of your height. And so that is identifying those people who have central obesity. And so amongst us South Asians, it is that ectopic fat, particularly liver fat, that is associated with our increased risk. So yes, we, unlike Caucasians, their increase in metabolic risk comes with increased fat. Whereas in South Asians, when we look across at every age, we are insulin resistant from a much, much younger age. So almost by the time we are diagnosed with type 2 diabetes, our pancreas is exhausted. We've undergone insulin resistance pretty much at every age, and then by the time we're diagnosed, we are exhausted. Our pancreas is exhausted, so we decline much more rapidly. We develop complications much more than, say, Caucasian. So we follow a different profile. And the thing I'd say about dairy, the reason I excluded it from my family's diet as a test was because they have these, there's some research in animals, and so this is an extrapolation that shows that microRNA, so epigenetic modulators, for example, in dairy, inhibit secretion of insulin from beta cells in the pancreas. So I just did this in my family because I was struggling to find a way that, in my view, was evidence-based to reverse those complications of diabetes. So dairy was my last port of call, and I was kind of thinking, okay, well, we've taken out butter, I can't see the benefit. We've taken out milk, I can't see the benefit. And then, we took out all dairy, and it was based on this, which is, essentially, if you think of milk as a dairy as something that infants are being given by their mothers, and during that life period of an infant, they have a diet that is just milk. They're not getting variations in what their diet is. So their pancreas is being somewhat inhibited because they get the same food, right? So it is those microRNAs in that dairy. And we only know this from animal studies. We don't have the same human studies. But that is why I removed it from my family's food. And that is the result that I saw there. So, yeah, I mean, we do need to be more proactive much earlier. We need to be thinking about that programming, in utero programming. So we need to even look at when women are pregnant, because one thing we do see in women with gestational diabetes is when you look at the blood of the fetus, they have epigenetic switches that put them at increased risk of dyslipidemia, beta cell dysfunction, and insulin resistance. So actually, this may be why at every life stage, we as a group are insulin resistant throughout our life course. So we have that much higher risk. So we need to be doing this primordial prevention. It involves a cultural shift where we don't normalize having all of these animal source foods in our diet in order to prevent generation after generation developing cardiometabolic disease in our communities.
Thank you. And there is one more question. There is so much data on reversal regression of diabetes. Please throw some light on that.
Yeah,
so if you want to say.
Absolutely. So one of the here in the UK, so if we look at the various diabetes prevention programs in India, the US, in China, and so on, the only one that we have cardiovascular outcomes for is the King Chinese diabetes prevention program. It is the longest running. So we do, of course, have that big lag. And they're also the only ones that focused on dietary quality, increasing fruits and vegetables, dietary quality. The others, like the American and the UK one, have predominantly focused on meal replacements in order to reduce calories. Of course, if you massively reduce calories and give people a shake, that is unsustainable, right? So as soon as they come off the shake, and it has to be medically supervised, they go back to doing what they were doing. So we're just delaying. Of course, there's some benefit in delaying the onset of diabetes, but what's the point of spending all that money and that intensive effort if you're going to just do something that can't be sustained?
I
And
agree.
so
Yeah.
so, to me, it's really a very stupid approach. We have this sort of approach as well, where we have a lot of low carbohydrate diets. Now, the thing we consistently see in prospective cohort trials is people on low carbohydrate diets have poor cardiovascular outcomes because they tend to replace this macronutrient of carbohydrate with saturated fats, which we know drives cardiovascular disease. So if you had a low carb plant-based diet with unsaturated fats, maybe that could work. But actually, we know that whole grains, high carbohydrate foods are associated with reduced risk of type 2 diabetes, reduced risk of cardiovascular disease. So this low carbohydrate dietary approach is not only treating numbers, but worsening outcomes. It's a terrible approach. But we also know from Kevin Hall at the National Institute of Health in the US. He's done metabolic ward studies looking at people on plant-based diets and low-carb diets. And what he found was that in people on low-carb diets, they lose weight more quickly. But what they lose when they put them in body scanners is very different. People on plant-based diets, they lose weight more slowly, but they lose fat. Whereas people on low-carb diets, they lose weight more quickly, but they start off essentially burning through their glycogen. Each molecule of glycogen is attached to 3 molecules of water. So the next thing they lose is water weight. And finally, they start to lose protein mass. So they lose their muscle mass. There's barely any fat loss within that. And that is consistent. Even when you look at longer trials, nearly all of the weight that is lost on a low carb diet is your glycogen from your liver, is your water mass, and then it's protein mass. There's very little fat mass loss, and that is really, really dangerous when we consider that our muscle is where we're storing more of our most of our glucose. It's really important metabolically. So an absolutely poor outcome for people on a low carb diet. So I think this is one of the worst things that anybody can do for their health.
Yeah, thank you so much. And I know we are running out of time here. Actually, we did run like a few minutes over. Thank you so
Sorry, I
much,
have long
Dr.
answers.
Sandhya Raman. No, but that was wonderful. Thank you for all the insights and everything. And thank you everyone for attending the session today.
Thank you, everyone. Thank you.
Thank you so much for having me. It's been an absolute pleasure to be here. Thank you.
Actually, I'm having very bad throat today. I've got caught with the throat infection. So I'm really grateful to you. And we had over 50 participants who joined us today. And
Lovely.
45 stayed until the very end. That's
Oh, great.
really reflecting how engaging, insightful, and beautifully well-researched the session was.
That's so
Thank
kind.
you, Dr. Sandhya, for such an insightful, thoughtfully articulated talk.
Thank you so much. Sorry,
Thank
I've
you, Dr.
interrupted you.
And thank you. And it was, I can see the passion in your talk and then the way you answered the questions. Thank you so much for your time today.
I really appreciate being invited. Thank you so, so much. It's been an absolute pleasure.
Thank you.
Thank you so much, ma'am.
Take care,
Thank
everybody.
you all for joining us. Thank you.